Shifa International Hospital in collaboration with Pakistan Society of Hepatology. Our respected panelists for this program are Professor Dr. Altaf Alam, Professor of Gastroenterology and Hepatology. He was Head of Gastroenterology and Hepatology at Sheikh Zahid Hospital. Professor Dr. Javed Iqbal Farooqi, Professor of Medicine and Gastroenterology at Lady Reading Hospital, Peshawar. Professor Dr. Kashif Malik, Head of Gastroenterology and Hepatology at Sheikh Zayed Hospital, Lahore. The above panelists will be joining us virtually, and Dr. Asif Masood, Consultant Radiation Oncologist at Shifa International Hospital, Dr. Azhar Shafi, Consultant Oncologist at Shifa International Hospital. Dr. Azhar Shafi will also be the facilitator of this program. We will be starting off with opening remarks by our course director, Dr. Shahzad Riyaz, who's Consultant Hepatologist at Shifa International Hospital and Regional Representative of Pakistan Society of Hepatology.
Well, thank you very much, Hajra, for the nice introduction. I would like to thank you all of our honorable speakers and panelists. I'll also like to add the name of Dr. Farooq, who is our senior radiation oncologist here, who has kindly attended the session as well. As you know, liver cancer is the third cause of common cancer death worldwide, and the global incidence has been increasing, more so in the developing nations because of the viral hepatitis. The management of HCC is becoming more complex as various modalities of treatment are coming up, and therefore we decided to have a discussion regarding this important topic. Pakistan Society of Hepatology was founded in 2001 in Karachi, and since then it has been doing a lot of work regarding development of this specialty and striving to improve the practice of hepatology in Pakistan. A few words about our hospital. Shifa Hospital's liver transplant unit was set up in 2012, and we have done over 1,000 transplants since then. Out of these, approximately 300 of them have been for HCC. We also have an established MDT in which more than 5,000 cases of HCC have been discussed over the years. We offer almost all of the important modalities that are used for the treatment of HCC. Now, without further ado, I will request our first, well, actually, I'll hand over to Dr. Hajra, who will introduce the speakers and will bring them accordingly. Thank you.
Thank you, Dr. Shahzad, for your inaugural words. I'm pleased to invite our first speaker, Dr. Mohammad Salih, who is Consultant Gastroenterologist and Hepatologist at Shifa International Hospital. He will be talking about epidemiology and screening of hepatocellular carcinoma.
Thank you, Shahzad, and thank you, Hajra, for a nice introduction. I'm really grateful to PSH, and I welcome, and I could see Professor Altaf Alam and Professor Javed Iqbal, my teachers and my seniors as always. We know that HCC is on the rise, and it will do so probably until 2030. So my topic for today is epidemiology and screening of an HCC. I don't have any disclosure regarding this presentation. This is the outline of my talk for today: the burden of the liver cancer, epidemiology of HCC, risk factors in etiology, and screening and surveillance. And in that, we will quickly touch upon the imaging and tests, frequency of surveillance tests, importance and effectiveness of surveillance, and quickly regarding the recommendations by the three main societies of the world. The burden of the HCC is that is the fifth most common cancer in the world and the second most frequent cause of death related to cancer globally. And it's 7% of all the cancer in the world. While 90% of those liver cancer are mainly HCCs, and HCC is the seventh most common cancer in women and fifth most in men. And it constitutes a major global health problem. HCC is the leading cause of death in patients with cirrhosis, with an annual HCC incidence of approximately 1 to 6%. And it has a strong male preponderance with a male to female estimated ratio is 2 to 2.5. So it's mainly dominant in men population. The incidence of HCC is going to rise and probably will peak in 2030 as predicted by the AASLD. And it's mainly driven by the chronic viral infection as well as by lifestyle related risk factors, including NASH and ASH. And cirrhosis is an important risk factor for HCC regardless of its etiology. And more than 90% of HCC arises on the background of cirrhosis. And 90% of HCC, we usually have an etiology or a known etiology for as an underlying cause for HCC, like hepatitis B, C, or cirrhosis, or NASH, or any other cause. But we do have an etiology for HCC. The worldwide incidence, this map shows the incidence throughout the world. And the more darker the areas, they are basically having more than 8% per 100,000 population of an HCC. The annual incidence rate is more than 8.4 per 100,000 populations, while the lighter one are having less one. If you look at Pakistan and India, we are somewhere between, we are less than 3.3. So our annual estimated risk is, we will come to that in a while. We don't have population-based studies, but we do have some predictions for that. And those clock-like dials represents the etiology. And it's basically in Europe, it's an alcohol, but slowly and gradually, NASH will take over as it's shown now. And in Asia, it's still the hepatitis B and C. But having said that, even in Asia, countries like Japan still have HCV. We don't have a population-based data to support our figures. However, the age standardized rates of HCC is around 7.4 per 100,000 population in men and 2.8 per 100,000 population in female, with the male to female ratio of 3.6 to 1. And the usual age of presentation is in the 5th to 6th decade. This is one of the papers from our center. It's the estimated rates of an HCC in Pakistan. When we say screening and surveillance, we first define screening, what a screening is. Screening is in systematic applications of tests or inquiries to identify individual at sufficient risk of specific disorder to benefit from further investigations or direct preventative action. While surveillance is a repeated applications of those tests or inquiries to identify individual at sufficient risk of specific disorder to benefit from further investigations or direct prevention effects. So periodically you apply those screening tests at intervals in a cost-effective manner to identify population at risk. Cirrhotics of anything, like either etiology, it's be it B, C, or alcohol or NAFLD, once you get cirrhosis, you are at risk for HCC. Along with those other conditions like HBV carrier, more so in Asian men and women, and with a family history of an HCC, these patients are at risk. And probably there are now evidence coming up that NASH without cirrhosis may also have HCC. So these patients are at risk and should be screened and surveilled. Is the screening and surveillance cost effective or not? We say it's cost effective that for any condition which an annual incidence of 1.5% and above, and all these conditions, including cirrhosis of any etiology, or hepatitis B, chronic hepatitis B, or NASH or HCV with advanced fibrosis, they have an incidence of 1.5 and above. So all these patients should be periodically surveilled and screened in the first instance. Why screening and surveillance is important? There is this Chinese studies which has been published long ago has proven that this would lead to the surveillance by ultrasonography and alpha-fetoprotein every 6 months leads to 37% reduction in mortality. However, this Chinese data is only in chronic hepatitis B patients and has not been extensively studied in other populations and etiologies. However, now further randomized trials are not possible. So we still say that based on these studies, one can extrapolate that screening and surveillance is effective. Adherence to the surveillance is also important. And astonishingly, the meta-analysis of almost 20,000 patients of 22 studies is showing that we are not that good at surveillance. And look at here, the overall adherence rate is around 52%. Europe being a little better than the US, and Asia is the worst. And it's more so in cirrhotics, we screen probably a little more and surveil more than in non-cirrhotics. So we are not doing fair as far as the surveillance and screening is concerned. We need to improve on that. The test for screening and surveillance, the common imaging tests which are available to us are ultrasound, CT scan, and MRI. Ultrasound being non-invasive, at low cost and readily available, while CT scan and more so MRI is more sensitive and specific. However, with a higher cost, and it's not that readily available to all of us. Ultrasound being more operator dependent and needs dedications and interest, and it's only used for screening and it's not a diagnostic tool. And for diagnosis, we will listen to the next speaker. Sensitivity of imaging modalities. Ultrasound has got a per patient sensitivity of around 64%, which is low if the lesions are smaller, while it increases or it becomes more sensitive if the lesion becomes better. And if we walk around like that, the CT scan is much better than ultrasound, and MRI is the best among the three. However, ultrasound has got some limitations and it's operator dependent. Heterogeneous liver parenchyma makes it at times challenging. Poorly marginated infiltrative lesions are difficult to pick, and lesions on the background of fatty liver and hypoechoic lesions are more so difficult to pick at times. So are there any alternatives to ultrasound, or can we think of to replace an ultrasound? MRI has been like there, and it has proved that it's more sensitive than the CT scan and ultrasound at around 84%. And abbreviated MRI protocol, which comprise 2 sequences only at a lower cost and a shorter time, is much better examination. However, and it is not part of the protocol yet, and it can be done in 7 to 10 minutes. While this MRI study, which I'm showing here, is basically 20 minutes apart after the contrast, and it is, when you expect, it is much superior to the ultrasound. So an abbreviated MRI may come in the future as part of the protocol, and especially more so in the NAFL population where smaller lesions are missed and not easily picked up on ultrasound. Recommendations by the 3 main societies of the world, EASL, AASLD, and APASL. EASL would say that surveillance should be performed by experienced personnel in all high-risk population, which means cirrhotics and those with advanced fibrosis, every 6 months. And they are strongly recommending this. They say that the biomarkers, they do not aid that much, and it's not cost effective, and may add only 7 to 10% to the ultrasound. But patients on waiting list for liver transplantation should also be periodically surveilled, as we may prioritize them or may offer some modalities to contain their lesions. So the recommendation is basically 6 months ultrasound by the EASL. And they say that all child A and child B should be surveilled. Patients with child C cirrhosis, only if they are on transplant list, should be offered surveillance. Otherwise, it's not cost effective. And patients with advanced fibrosis should also be surveilled. AASLD offers the same as a surveillance, all cirrhotics and all patients with chronic hepatitis B, more so in Asian men at above 40 and women in above 50. And patients with NAFL or hepatitis C with advanced fibrosis should be surveilled, screened, and then followed by surveillance. AASLD recommends surveillance in cirrhotics because it improves overall survival, and it says that ultrasound with or without alpha-fetoprotein every 6 months. And AASLD also says that patients who are a child C and not on transplant list may not be surveilled because you are not offering them a potential curative treatment. AASLD recommends that if you do an ultrasound, plus minus alpha-fetoprotein, and if there is no lesions, follow them in 6 months. However, if there is small lesions, it's better to repeat the imaging in 3 to 6 months with or without AFP, sorry. And if there is a lesion, then of course you follow the diagnostic protocol, which the next speaker will be talking about. So AASLD says that ultrasonography is used as a screening and surveillance tool and not a diagnostic. And there is something else used for diagnosis. And they also say about contrast enhanced ultrasound, which is useful and maybe as good as a CT dynamic or an MR dynamic for the diagnosis of an HCC. And it says that alpha-fetoprotein is not recommended as a confirmatory test, and the cutoff of alpha-fetoprotein should be at 200 or more for the surveillance program when used in combination with ultrasound 6 monthly. While patients who have been, who has achieved viral suppression or the virus has been eradicated, a lower cutoff may be taken because to pick early lesions. Again, they are saying that all cirrhotics and hepatitis B patients and patients with hepatitis C or NAFLD with advanced fibrosis should be offered screening and surveillance. AASLD recommends biannual ultrasound and alpha-fetoprotein-based surveillance in all these patients. In summary, screening and surveillance is important to detect early HCC. Early detections may means potential and curative options for these patients. A proper ultrasound plus minus alpha-fetoprotein every 6 months in patients at risk is recommended, and adherence to the screening and surveillance can be approved by only 2 things, and that is patient education sessions and CMEs activities like these for physician to remind us all that these things are important and they do matter. I thank you all for your kind listening.
Thank you, Dr. Mohammad Salih, for such an elaborate talk. Our next speaker is Lead Interventional Radiologist, Consultant and Chief of Radiology at Shifa International Hospital, Dr. Atif Rana, who will brief us about imaging diagnosis of HCC.
So I'm going to be talking about imaging diagnosis of HCC. I have no disclosures. We'll briefly talk about liver segment anatomy. I'll talk also briefly about the technical aspects of how to do an adequate CT or an MRI. My main focus is on imaging patterns of HCC on both CT and MR. That's what I'm limiting myself to. I'm not talking about contrast-enhanced ultrasound. I'll briefly touch upon the imaging evaluation of metastatic disease and also introduce U-RADS here as well on this forum. So liver segments, we all are pretty familiar with this. Just to go over basic anatomy, we have 8 functionally independent segments in the liver. Each segment has its own vascular inflow, outflow, and biliary drainage. And in the center of each segment, there's a branch of the portal vein, hepatic artery, and bile duct. And in the periphery of each segment, there is a vascular outflow through the hepatic vein. And this is a diagram. And if you looking from the front, these segments go in a clockwise fashion from segment 2 to 8. And segment 1 is the carotid lobe at the back. The middle hepatic vein is what divides the liver into right and left lobes, and this vein runs from IVC to gallbladder fossa. The right hepatic vein is used to divide the right lobe into the anterior and posterior sector, and the falciform ligament divides the left lobe into the medial and lateral segments. The portal vein is used to divide the liver into upper and lower segments. And this is how you would see that these segments on cross-sectional imaging. So on a higher cut on the CT image, you'll be seeing segments 2, 4, 8, and 7. whereas more inferiorly, you'll see segment 3, 4, 5, and 6. Moving on to a role of imaging, early detection of HCC is important because we all know there are potential curative treatments and life-prolonging treatments available. Dr. Salih mentioned about the surveillance and use of ultrasound for that, but the diagnosis relies on CT and an MR, and these are multiphasic examinations. Imaging features on CT and MR permit diagnosis of HCC with a positive predictive value approximating 100%. HCC is one of the few tumors where histopathological diagnosis is not required, and imaging may be used to establish the diagnosis non-invasively. And treatments such as liver resection or even transplant are taken up without a confirmatory biopsy. There's some limitations of biopsy, such as false negative results in a very small tumor, impractical for evaluating multiple lesions because you cannot biopsy all of them. And there are small risks, obviously, of needle tract seeding and bleeding. So given all these factors, I think a non-invasive diagnosis is really helpful, and CT and MR have a very good role in that. And biopsy is reserved for indeterminate nodules that do not satisfy radiological criteria for HCC. We need to be able to diagnose and differentiate a tumor, HCC, from non-malignant cirrhotic nodules, such as regenerative nodule, the dysplastic nodules, low-grade or high-grade, intrahepatic cholangiocarcinoma, as well as other various benign lesions in the liver. The per lesion sensitivity of MR imaging and CT is pretty high. Looking at these, if they are more than 2 centimeters in size, they're pretty equal, almost 100%. Whereas in smaller lesions, MR has slight edge. Some of the advantages of CT versus MR is CT is widely available, it's more rapidly done, it's more robust, needs less expertise to perform and as well as interpret the images. Obviously, disadvantages are radiation, contrast, and low soft tissue contrast as well. MR has advantages that it has higher soft tissue contrast, so you can theoretically permit assessment of a greater number of tissue properties, which can help you in lesion detection and characterization. It's more time consuming, as you obviously heard in the previous talk as well. It's less robust, more prone to artifacts as well. And it does require greater expertise to perform and interpret the images as well. MR imaging may be preferred over CT at many academic centers, but right as of now, there's insufficient data to recommend MR imaging over CT in a community setting or a less specialized center. So just briefly about the technical aspects, it's a multiphasic scan. You all hear about these dynamic scan, multiphasic scans when you see these scans in your daily practice. CT scan is the first phase is non-contrast, although some centers do not do a non-contrast CT, except when they have been treated, the lesions have been treated before. Also, with the new arrival of dual energy CT, we are capable of getting virtual non-contrast scans. And although this is not widely available, the dynamic scan constitutes of a late arterial phase, followed by a venous phase, and a delayed phase scan, which is done at 5 minutes. The late arterial phase scan is when you see the arteries enhancing and minimal portal vein enhancement coming in as well. And that's crucial because some of the earlier arterial phase scans can miss HCC, and you can miss an important aspect of diagnosis. These are LIRAD's minimum technical recommendations for doing a CT scan. They're pretty standard. I'm not going to go over these details. MR, essentially T1 in and out of phase before contrast. We need a T2 sequence, optional DWI sequence. And again, the dynamic scan constitutes of a post-contrast arterial, venous, and delayed phase scan. There are 2 contrast agents available. One is the more widely used extracellular contrast, and the newer agent, hepatobiliary contrast, the gadolinium, which has a role as well. These are some minimal technical recommendations as per LIRADS. Again, I'm not going to go into the detail for these. Let's talk about the imaging pattern in HCC. It's a pathological continuum. It's a multi-step hepatocarcinogenesis, and is characterized by progressive dedifferentiation of phenotypically abnormal nodular lesions. And it leads to expansion of successively less differentiated clonal populations, and eventually produces lesions with malignant phenotypes. So you have cirrhotic nodules and low-grade dysplastic nodules and high-grade, and then eventually HCC. Talking about the cirrhotic nodules, these are also known as regenerative nodules. And they are innumerable, well-defined, rounded regions of cirrhotic parenchyma surrounded by scar tissue, and can range from 1 to 15 millimeter in diameter. How do they look on imaging? They are isoattenuating at unenhanced CT and isointense on unenhanced T1 and T2 images, as well as DWI. They may be occasionally hyperintense on T1 images and hypointense on T2, and mimicking a dysplastic nodule. So sometimes they can look similar to dysplastic nodules. They don't have arterial phase enhancement. Dysplastic nodules, either low-grade or high-grade, they appear as isoattenuating on CT or hypoattenuating in arterial portal and delayed phases. They can be hyperintense on T1 weighted images and iso or hypointense on T2 weighted images. And this is supposedly from copper or iron deposition. If they have very high concentration of iron, they appear very low signal on T2, and these are labeled as cirrhotic nodules. So, as I said, there can be overlap in imaging appearance. This patient has high T1 signal on the top images. You can see high signal areas. And on the bottom in the T2, there is low signal, suggesting that these are dysplastic nodules. But on explant, when the patient had liver transplant, there was no dysplastic nodule on this patient. So these dysplastic nodules typically don't enhance, but they can have. The high-grade dysplastic nodules can show arterial phase enhancement, but there should be no washout and no capsule, because that would push them into HCC category. So if the nodule, just to rephrase again, if a nodule does not show arterial phase hyperenhancements, it can be one of these nodules, a cirrhotic nodule, dysplastic nodule, or even an early HCC. Some value of hepatobiliary contrast agent. It's a strong predictor of pre-malignancy or malignancy, and its presence favors high-grade dysplastic nodule or early HCC. So what we do with hepatobiliary contrast is we do a delayed scan at about 20 minutes, and if the lesion is hypointense, that's what we give a differential as. We don't have this available in Pakistan widely. Some centers are importing it. It has high cost. It's in the process of being registered. So hopefully we'll see that soon as well in our practices. So what are the hallmark diagnostic features of HCC on imaging? Moving on to progressed HCC. Arterial phase hyperenhancement. This enhancement is unequivocally more than adjacent liver. In this portal or delayed phase washout. Additional features such as a capsule, enhancing capsule, is also important. And this is a typical HCC. You can see arterial enhancement and washout on the venous phase. This combination of arterial enhancement and washout is highly specific for HCC. But these are patients who are cirrhotic or Hep B positive patients. How specific is this? For HCC more than 20 millimeter or larger, this specificity reaches 100%. For lesions which are 10 to 19 millimeter, almost 90%. Capsule is also important. This can be true capsule or sometimes pseudo capsule. Can be used as an additional feature in absence of washout appearance. Some additional features which favor HCC, satellite nodules, which are considered as intrahepatic metastases, tumor thrombus, and if a thrombus shows neovascularity, venous expansion, or is adjacent to HCC, that's more likely to be a tumor thrombus. There are some ancillary features which are part of U-RADS as well. I'll come over to that as well. Intralesional fat favors HCC. Corona enhancement, which is the enhancement surrounding the lesion that favors HCC. Nodule in nodule architecture, as you can see on this image. This also suggests a progressed HCC within a dysplastic nodule or early HCC. Metastatic workup, just briefly, most commonly we do CT scans, but you can obviously do MR and a PET scan as well to look for metastases. And the Mets are most common in frequency in lungs and then nodes or bones. Moving over to LIRAD system, liver imaging reporting and data system. It was originally released by ACR in 2011, and since that's been revised 4 times. And the most recent revision was in 2018. And I believe the next one is due either this year or next year. So this is to be used with liver lesions in patients who have liver cirrhosis and chronic hepatitis B virus without cirrhosis. And it reflects the probability of HCC and is based on the typical CT and MR findings in HCC. This is one of the flow diagrams, and we'll talk about some of these in subsequent slides. So these are the major features which LIRADS relies upon. Again, arterial enhancement, arterial phase hyperenhancement in a non-rim fashion. That's important, and that should be greater than the surrounding liver. Please note, a rim enhancement is not a feature of HCC. It's not specific. Non-peripheral washout, again, decrease in attenuation or intensity from earlier to later phase. That's a major feature. Capsule, we already mentioned this, is a major feature. Size also becomes important in the triage and when you're following this table. And I'll show you the examples shortly. Threshold growth is increase in size of 50% or more within 6 months' time during the follow-up imaging. And that also is important. LIRADS uses a term observation when we're not sure whether something is a lesion or a pseudo-lesion. But if you are sure it's a mass, you can use a term mass or a nodule. So the categories for LIRADS are definitely benign, which is LIRADS 1, probably benign, LR2, intermediate probability was LR3, probable HCC, LR4, and definite HCC, LR5. LRM is high probability of being malignant, but not necessarily HCC. So these are some of the benign etiologies which fall into LIRADS 1 when you're definite that this is a cyst or a hemangioma or hepatic fat deposition, for example. We can call it LIRADS 1. LIRADS 2 are when you are not very sure about these, but you're thinking about benign etiologies, and you can classify them as LIRADS 2. So this is one of the aspects of LIRADS, that it gives you recommendations about the workup and follow-up as well. So I'm just focusing on the untreated observations, patients who have not been treated so far. And all these groups have some consensus guidelines, such as biopsy or follow-up. LIRADS 3 is intermediate probability. LR3 observations vary from benign lesions to dysplastic nodules to HCC. Some of these can be vascular pseudolesions. Approximately 37% of LR3 lesions are HCC and 39% are malignant. So what are the lesions that are placed in this category? Nodules with features of FNH or hepatic adenoma. Nodules which are less than 20 millimeter without major features, the ones we talked about, but with one or more ancillary findings of malignancy, such as intralesional fat, T2 hyperintensity, diffusion restriction, and hepatobiliary phase hypointensity. So these less than 20 millimeter nodules can be placed in LIRADS 3. Nodules which are more than 20 millimeter, non-enhancing, and without any major or ancillary features can be placed in LIRADS 3 as well. Moving on to LIRADS 4, of all LR4 observations, about 74% are HCC. So these can have no enhancement on the arterial phase, or they can have arterial phase enhancement. Again, it should be non-rim enhancement. So, and we classify them according to size. Just going over a few examples. For example, this is a table I showed before, part of that. And this is important, categorizing lesions into LR3 to LR5 categories. So let's say you have a lesion which is not showing an arterial phase enhancement. Next thing you do is look at the size of the lesion. So let's say this is less than 20 millimeter. Next thing you want to know is what are the additional major features present. So 2 or more features, either capsule, washout, or threshold growth. If there are 2 of these present, you can qualify this, categorize this as LR4. Again, if no enhancement, if more than 20 millimeter, even one of these additional features, such as enhancing capsule or a non-peripheral washout, you can put that lesion as LR4. Moving on to LR5, of all LR5 lesions, 95% are HCC. So again, same example. Suppose you have a lesion in patient with liver cirrhosis, and there's arterial phase non-rim hyperenhancement. And let's say the size is 15 millimeters. So it falls into this box. There's a capsule and washout and later phase. This means there are 2 additional criteria present. So this will result in an LR5 classification. LRM is a separate category. So it should be applied to malignant appearing lesions that do not have typical appearance of HCC. So non-HCC malignant lesions either show a targetoid appearance, a rim-like enhancement, and a peripheral washout and delayed central enhancement. So you're thinking these are tumors, but these are not typical HCC. These can also be non-targetoid with an infiltrative growth pattern, such as this lesion. This is a cholangiocarcinoma. You can see rim enhancement, strental necrosis, and we would classify this as LRM. So if you look at the right-hand side of the screen on LRM, this workup often includes a biopsy in such a lesion, and you have to prove your diagnosis before proceeding with your treatment. So same with tumor thrombus. If there is a tumor, a portal vein tumor thrombus, according to this, that has a separate category. And depending on the MDT discussions, you may or may not need a biopsy to prove this pathology. So in conclusion, HCC imaging, we know the techniques are pretty standardized. LI-RADS also stresses upon that and gives you minimum standards how to image these patients. CT and MR are cornerstone of imaging. MR does have a better role in smaller lesions. In LI-RADS has tried to standardize the reporting and give better communication with the referring physicians. It is now also incorporated with the AASLD guidelines. It is complex. I haven't gone into a lot of details of LI-RADS, but it answers pretty much lots of questions which are clinical. Thank you for your attention.
Bismillah ar-Rahman ar-Rahim. I have no disclosures. So this is a slide that we're all very familiar with. And interventional radiology, usually we think of treating patients with the intermediate stage cancer, and that's only about 20% of the patients. Interestingly, there's been a study, the Bridge study, and this showed that globally, almost 80% of patients treated for HCC were outside of those guidelines. And similarly, in another European study, 40% of their patients were outside of the traditional guidelines recommended for TACE. Now, we all know that the natural stage is to move from left to right. However, there is the newer concept of stage migration where you actually downstage the patient. So I'm going to talk about the indications for TACE in the different stages, not the intermediate stage, but stage 0, stage A, stage C, and so forth. And I'll give you some examples. So these are starting with stage 0 and stage A. So here we have a lesion, and the reason why this hasn't been ablated is because it's in close connection with the adjacent bile duct. And obviously, a biliary stricture from thermal ablation would be catastrophic, and he'd require lifelong drainage. So this was a suitable patient for TACE. As a bridge to transplant, which is something we do in Shifa, and it's mainly because of to help with the waiting time, and studies have proven that there's improved post-transplant overall survival. TACE and ablation. So for lesions which are between 3 and 5 centimeters, this is now one of the recommendations, and when we get a much better result, both in terms of recurrence-free survival and overall survival. Now, if I go for indications for TACE in the BCLC-C category. So again, intolerance of systemic therapy, which is quite common, liver dominant, ECOG1, and some other examples. The only thing is, the caveat is that there should be a MDT discussion before taking such patients, and that is how we manage these patients in Shifa. These are just some of the side effects with sorafenib. And we can see that the side effects are quite common. So patients obviously who can't tolerate systemic chemotherapy. The other problem is with ECOG. While it's a very good differentiator, for example, ECOG 0 and ECOG 1. ECOG 0 says that you have to be able to perform strenuous physical activity. But what about if this 60-year-old guy is an office worker? You know, maybe he can't perform strenuous physical activity anyway. So, you know, PSO and PS0 and PS1, you know, it's difficult to differentiate. Another special indication. So whenever you have a ruptured HCC, it doesn't matter what the bilirubin is, you would proceed and you would embolize. This is another patient who's actually bleeding into the biliary system. So again, he's having a chronic drop in hemoglobin. So he was also embolized. The first patient, he had a high bilirubin, and following embolization, the bilirubin actually did go up as expected, but then it did return to baseline levels. So the stage migration concept, is it a violation of the guidelines? No. Choosing a different treatment is okay. We can migrate from left to right. Well, usually it's left to right, but we can go from right to left. But the MDT discussion is mandatory. TACE and immunotherapy. So conventionally, we've been using the tyrosine kinase inhibitors, and we have a significant side effect, as much as 80%. So we know the side effects are much fewer with immunotherapy. The only thing is that as a monotherapy, the response rate is only 30%. So what we advise, if you've got a large HCC, especially in the palliative setting, you're better off embolizing it first, releasing all these tumor antigens into the bloodstream, and then giving them a few cycles of immunotherapy, because you'll get a better response. So it's about combining the two modalities of treatment. I know my other colleagues will go over that in more detail. Just two other examples. So this is a patient who presented in July 19. Unfortunately, this is his initial presentation, and you can see this lesion sandwiched between the middle and right hepatic veins. This is the same patient going further down, and the same patient. I don't have images of his microwave ablation, but we did a microwave ablation, and then a few weeks later, we did a conventional TACE using lipiodol. So the white material you can see is the iodized oil. And we achieved a complete remission. So he was absolutely fine. He then presented in May 2021 recently, and you can see the slightly whitish area centrally near the ablation zone. So he's now got recurrence sort of 2 years later, and that's where the arrow is. And he's also developed a new lesion more posteriorly. So the lesion, this is actually not May. This should have been August 2017. So I used alcohol on this occasion, and this was the chemical ablation. Now, The one posteriorly, you could argue we could have done with RFA or microwave, but the one centrally over here, this was not amenable to thermal ablation. We've got the left and right hepatic ducts coming in. This is a very high risk no-go area. So conventional ablation is not an option. These central tumors are very small feeders from the arterial supply. And, getting rid of it completely on TACE, on standard TACE would be very difficult. So we did chemical ablation, and you can see the image on the left. You can see that lesion is completely disappeared. The one on the right shows the posteriorly, you can see the tumor. And similarly, again here, the one on the left showing complete response, and on the right, you can see where the lesion was. So this was with CT-guided alcohol ablation for when you want to target people. The guidelines say you can use it in up to 2 centimeters. Previously, they used to say 1 centimeter. So it has to be very focused. This is another patient. Sorry, this one should have been August 2017. So this patient, he's got reasonable liver function, but his AFP was more than 30,000. He's an ALB grade 2. His platelets were okay at this time. Subsequently, following sorafenib, he dropped his platelet count to 29,000. So his PALB score would have been even less. And the CLIP score, which is supposed to give you an overall survival for general populations, but it's not very good for individual patients. But this guy was only going to live 4.5 months. So that's August 2017, not May 21. So he has a large arterioportal shunt. So that's the first problem. So here you've got the angiographic phase images, and as we inject contrast, you're not seeing the tumor very, very well, and you're seeing filling of the portal vein. So the first thing was to try and identify and find the particular shunt, the actual vessel. And this was done without the use of a microcatheter. So this was where the shunt was, and you can see that that's the shunt filling the portal vein. So the first step was to close the shunt. Following that, he had a conventional TACE in October, and now you can see the tumor much better, and we've gone in via the right and left hepatic arteries. He then has another 4 sessions of TACE in between. He was on sorafenib, that was stopped because of his play. He dropped his counts. And in his March 2021 CT, he's got no measurable disease. And he also actually had portal vein invasion. So we had, not only did we have a shunt, we had portal vein invasion, and we had a large tumor. And his AFP is 2.2 at the moment. So he's done very well. The only reason he didn't want to go for transplant is he had a minor stroke, and there were some affordability issues. Now, just briefly touching on the role of TARE in HCC. So first of all, what is radioembolization? So radioembolization is the same as TACE, except that the embolic used is a Y90, which is a beta emitter. But the principles are the same. You have to get into the vessel, you have to target the tumor. So there are lots of synonyms: CERT, TARE, Y90, and the 2 companies that make them are Cerspheres or Theraspheres. So this is, so it's the beta, so it's a beta emitter. So this is just showing the penetration. So they only travel for 2 to 3 millimeters on average. They can travel up to 12 millimeters. So when you deposit them within the tumor, it's a very localized deposition. And over here you can see, like, this is the maximum range is 11.4 millimeters. So it's actually much less. Now, this is an important slide because some of the negative data that's come out in some of the studies up 2 years ago in the Cervinib and the Sarah trial, and that's because they argued that there wasn't a sufficient dose given into the tumor, and that's why the response wasn't good. So it's important to get the dosing correct. And this is just showing, again, the range, that the median range is about 2.5 millimeters. So the concept of CERT is to selectively target a very high radiation dose to the tumors within the liver by minimally invasive means of a microcatheter. These are actually very small in size, 32 microns. So the smallest embolic agent we have in our conventional interventional radiology suite is around 50 to 150, and we sometimes use that in prostate embolization. So this is actually smaller than the conventional embolic agents that we have. Half-life 64 hours, that's from the factory. So within 64 hours, it has to leave the factory, get on an aeroplane, clear customs, and get into the hospital. And that's the rate-limiting step. This is just showing the passage through into the arterial circuit, but it doesn't actually cross the capillary bed. So the image isn't completely displayed here, but it would have showed that it gets stuck on the arterial end and doesn't migrate across. Okay. So the practical use of certain HCC. All right, so in early stage prior to radical treatments, so to downstage as a bridging therapy for liver transplantation, I think one useful thing is as a radiosegmentectomy, because you can then actually get hypertrophy of the future liver remnant. In intermediate to advanced stage, especially when you're dealing with portal vein thrombosis, which was one of the initial indications when you've got vascular invasion, about 10% of patients don't show a response to TACE. The advice is that you give them another TACE, and if they still don't respond, well, that's the literature. 10% don't actually respond, non-responders. And this is sort of roughly where you would fit CERT in. So you've got it in the early stage, and you've also got it in the intermediate stage, and even in stage C. There are lots of different studies showing good response, and we can't go into them in any detail, but certainly even you've got better overall survival and tumor-free survival. What I will come on to is over here. So these were the three trials which were basically saying that TARE isn't very good. And subsequently, there's been some more research done, and the Dossisphere study. And what they basically said was that they weren't giving sufficient dose. The other thing is that in the trials, those patients who were taking sorafenib were on the 800 milligrams, sort of the BD dose, which we know often a lot of our patients are unable to take. And so there are new guidelines coming up, and this is from the Lancet recently. And saying that basically is if you get the dose correct, you'll get a much better result. On another note, most of the TARE cases I did were actually in non-cirrhotic. So especially when you're dealing with metastatic disease, you can get a very good result because you don't have the problems of liver function. So most of our cases were colorectal mets, but you can also do it in breast cancer mets, in cholangiocarcinoma. The one problem with TARE is that the bilirubin cutoff is 2, not the conventional 3. So you do need to have good liver function. So when you're dealing with cirrhotic patients, that's just one of the considerations to bear in mind. And this is my last slide with 2 seconds left. So positive randomized studies in overall survival. New trials are ongoing. It's very promising. And not only in HCC, but especially in metastatic disease. Thank you.
So I'm going to discuss the role of systemic therapy for HCC. We've got a few oncologists on as our panelists as well, who I'm sure will be able to help me out if I get stuck. Okay, I have no disclosures. Just a few quick words. Dr. Salih has covered this quite in detail, but liver cancer is overall on the rise, and its incidence is especially increasing in our side of the world. Because of increased prevalence of viral hepatitis. BCLC is the most used staging system in the Western country for the management of HCC. But it's the MDT which is the crucial aspect in the management of any patient with HCC. The MDT should comprise of hepatologists, radiologists, the surgeons, oncologists, palliative cares, and pathologists. Unresectable HCC, unfortunately, has limited options, best supportive care, local regional therapy, and some systemic therapies. Although the progress has been slow, the treatment landscape for HCC has recently evolved quite rapidly. The top line suggests the first-line therapy development, with the sorafenib coming with the SHARP trial in 2007, lenvatinib with the REFLECT trial in 2017, and more recently the atezolizumab and bevacizumab combination. The bottom line is the second-line therapy with the regorafenib coming secondary to the RESOURCE trial, cabozantinib with the CELESTIAL trial, and ramucirumab with the REACH-2 trial. However, there is quite variability in the treatment options available throughout the world. This is because of licensing, costing as well. And just to summarize, the current treatments that are available are as follows. As a first line, there is sorafenib, lenvatinib, and atezolizumab and bevacizumab. We'll be talking a bit more detail on this because this is a relatively new kid in the block. With the second line, we've got regorafenib, cabozantinib, pembrolizumab, nivolumab, and ramucirumab. Now, pembrolizumab and nivolumab had accelerated approval in the US on phase 1 and 2 trials. Unfortunately, nivolumab's phase 3 trial has come out to be a negative study. They are not widely used throughout the world. Ramucirumab is an antibody to VEGF and is quite expensive, whereas cabozantinib is a tyrosine kinase inhibitor. So we're all familiar with the SHARP trial and the Asian Pacific trial. These are the trials that brought sorafenib into play for the management of HCC. Unfortunately, in either trial, the absolute survival gain was less than 3 months. Lenvatinib was then introduced through the REFLECT study, which was a non-inferiority study, which suggested that it was at least as good as sorafenib. However, the side effect profile was much better than sorafenib. So there's a huge unmet need to improve the overall survival in patients with unresectable HCC, and that is where the checkpoint inhibitors have come into play. So this is just a quick video letting us know how the checkpoint inhibitors work. So our immune system consists of various cells, including the T cells. The T cells have receptors which can identify infected or tumorous cells. They come close to these cells, join them with these receptors, the T cells become activated, and that's how they identify these as disease cells and destroy them. The tumor cells, however, have developed ways of avoiding our immune system. And they do it by, in addition to activating the T cell receptors, they activate a checkpoint receptor, which inhibits the T cells and therefore prevents the T cells from destroying it. The checkpoint inhibitors are chemicals that can be molecules that can be used to inhibit these PD-1 receptors. And therefore, they help the T cells identify these abnormal cells as tumor cells and cause their destruction. Unfortunately, the initial experience with the checkpoint inhibitors was not great, and as they did not significantly improve the overall survival in the Checkmate 459 trial with nivolumab and the Keynote 240 trial with the pembrolizumab. During this time, other chemicals were also being investigated, and one of them is the vascular endothelial growth factor, or the VEGF. And it was noticed that it has overexpression in patients who've got HCC, and in the patients that have got overexpression, the prognosis is poor. High levels of VEGF in the liver also support the hypothesis of VEGF-dependent modulation of immune tolerance. And that gives us the scientific basis or the scientific rationale for combining the two drugs, the atezolizumab, which is a checkpoint inhibitor, and the bevacizumab, which is an anti-VEGF. This came into play with the IM-BRAVE trial 150, in which these two medications were used in first-line management of advanced HCC. This trial was published in 2020. There has been an update of the patients of this trial with a further 12-month follow-up, and the data was presented in the Gastrointestinal Cancer Symposium in 2021 by Dr. Richard Finn. So we'll be discussing this data a bit more in detail. So the I Am Brave study had a key eligibility of patients who had locally advanced or metastatic unresectable HCC with no prior systemic therapy. They were stratified according to the regions, their ECOG status, presence or absence of macrovascular invasion, extrahepatic spread, and the patient's baseline alpha-fetoprotein, whether it was more or less than 400. They were randomized to receive either atezolizumab, bevacizumab, or sorafenib at a dose of 400 milligram twice a day. The medications were continued until there was loss of clinical benefit or unacceptable toxicity was noticed. The endpoints was overall survival and progression-free survival. The baseline characteristics in both groups were quite similar. So the overall survival in the initial study, the primary endpoint was noticed to be improved. So the median overall survival at 6 months was 85% with the atezolizumab bevacizumab combination, as opposed to 72% with the sorafenib combination. The updated overall survival suggested an improvement of 19.2 months survival as compared to 13.4 months with sorafenib alone. There was subgroup analysis of the overall survival, and it was noticed that patients who had viral hepatitis, patients whose AFP was less than 400, and patients who had extrahepatic spread or macrovascular invasion did better with the atezolizumab bevacizumab combination. Similarly, with the progression-free survival, the median survival at 6 months was 55% with the atezolizumab bevacizumab combination, as opposed to 37% with the sorafenib combination. The updated data of the progression-free survival was up to 6.9 months versus 4.3 months with sorafenib alone. Similarly, with the subgroup analysis, it was noticed that, especially with hepatitis B, there was a significant improvement. Patients who had less than alpha-fetoprotein of less than 400 and patients who had extrahepatic spread or macrovascular invasion fared better with atezolizumab bevacizumab combination. There was also data about the patient-reported outcomes. So this combination delayed the time to deterioration of patient-reported quality of life compared to sorafenib. The delay was from 3.6 months to 11.2 months. And the symptoms that were delayed include appetite loss, presence of diarrhea, fatigue, and pain. The safety profile was also quite comparable with other systemic therapies, with hypertension, pyrexia, increased ALT and proteinuria being a bit more with this combination. And this study led to the FDA approval of atezolizumab and bevacizumab as a first-line therapy for the management of unresectable HCC. And it has also been included in the NCCN guidelines for the management of HCC. So there has been various other studies that have been done on this data. So one of these was the extrapolatory efficacy and safety results of this combination versus sorafenib in patients with unresectable HCC who had prior local regional therapy. And the survival benefit with this group over sorafenib was seen regardless of the number of prior local regional therapy. However, atezolizumab bevacizumab seemed to have more benefit in patients who had 1 to 2 versus more than 3 local regional therapy, suggesting an optimal time to switch from local regional therapy to systemic therapy. Now, there are certain unanswered questions with regards to these systemic therapies, and I've just summarized some of them. So should we use these combination in patients who have had solid organ transplants, in patients with HIV and patients who have had autoimmune hepatitis? Can these medications be used? Can we use them in patients who have significant cardiovascular disease, diabetes, or metabolic syndrome? What about fibrolaminar or mixed HCCs and HCCs with other histological subtypes? Can we give them in patients with child B or C disease? What about elderly patients or patients with a history of significant bleeding and patients that are on hemodialysis? So in summary, nobody knows the complete answer to these. There are case reports and case series. However, each decision has to be taken on an individual basis in an MDT setting for these particular type of patients. Another unanswered question is, what do we do on patients who fail with this therapy? But the current expectation for subsequent treatment failure on atezolizumab bevacizumab combination include sorafenib and lenvatinib as a second-line therapy, and for third line going on to regorafenib, ramucirumab, and cabozantinib. Now, these medications are very expensive as well, and there have been studies to see the cost effectiveness of this combination versus sorafenib. And in this particular study, these medications were not found to be cost effective from a US taxpayer perspective. And therefore, this has led to various studies to see if we can find biomarkers to identify the patients who will do better with these medications. So on the ILC 2021, there has been some published data regarding the 11-gene INFAP signature, which may predict the response to anti-PD-1 therapy as a first-line therapy in advanced HCC. This data has been validated in other tumors as well. However, again, these tests are quite expensive and unfortunately are not available in developing countries. A simpler score called the Graffiti score has also been developed. This is based on the CRP of 1 or more and an alpha-fetoprotein of 200 as a cutoff. And based on this, you are given either a low Graffiti score or a high Graffiti score. Patients who have a low Graffiti score have a median overall survival of 21.8 months with this combination, as compared to patients who have got a high Graffiti score, the survival is only 5.3. Months. So again, this can be used in selecting patients before giving these expensive medications. Now, this trial was quite successful, the I Am Brave trial, and it has sparked multiple ongoing first-line therapy trial combination trials. So we have to watch this space because the management of HCC is going to become very complex in the next few months and years to come. So in summary, systemic therapy landscape is evolving rapidly. Checkpoint inhibitors have provided a new ray of hope, with atezolizumab bevacizumab providing the longest overall survival. HCC management decisions continue to remain complex, and these decisions should be made in an MDT setting. Thank you.
Thank you very much. Once again, Bismillah ar-Rahman ar-Rahim. I'm trying to limit myself to liver resection because other panelists are going to talk about liver transplantation in the later part of the presentation. Okay, so I have no financial disclosures. So as we've gone through the introduction a couple of times, it's the 5th most common cancer and the 3rd leading cause of cancer-related deaths in the world. About 80% of the cases are due to underlying liver cirrhosis, as we all know, and 3 to 10% is the annual incidence of HCC in compensated cirrhotics. The risk factors, again, cirrhosis due to any other cause, metabolic liver diseases, alcohol abuse, and environmental factors also come into play with aflatoxin, contraceptive pills, etc. But the leading cause is the risk factor are the chronic hepatitis B and C cirrhosis. So we've gone through a couple of classification systems. Many people have tried to classify these tumors. I'm going to limit myself to the BCLC staging algorithm and treatment algorithm. We're going to see this slide many times during the course of today. So we all know that it is the very early tumors which are stage 0, where there's a single lesion less than 2 centimeters with preserved liver function and good performance status, where we offer the most curative options like ablation and resection. And again, stage A tumors, where we can still offer, some of them can be offered liver resection and some of them can be offered liver transplantation. So this is all pretty standard, and BCLC is about 20 years old now, and it has been widely used in the world, in Europe and North America. So let's talk about the standard resection patient. Obviously, we all know that surgery is the only potential curative treatment, which involves liver resection and liver transplantation. So I will focus myself on liver resections. So the ideal candidate is someone who has 1 lesion less than 5 centimeters, preferably, or larger, but without invasive profile, in an asymptomatic patient. No portal hypertension or hyperbilirubinemia with a good liver function, classified as CTPA. and the results are reasonable. Mortality, in hospital mortality is less than 5%, and 5-year overall survival is about 70%. But the only problem remains is the high recurrence rate, which can be as high as 70% at 5 years. So our other bodies, international bodies, have also tried to give a guideline about liver resection. And if we look at the screen, we know that all of them agree that there should be no extrahepatic spread when you're offering liver resection. And both the bodies say that you resect these patients when you have a child class A or MELD less than 10. So as you go ahead, you see in a puzzle that they are extending the indication, and then now they're going towards not a specific size, but they're saying resectable tumor, regardless of vascular invasion. So, and they're not bothered really about the number and the tumor size. And they're also stretching on the liver functions when they say you can resect these tumors in child A or child B class. All of them agree that the future liver remnant should be more than 40% in cases of cirrhosis. And also, about portal hypertension, it's not an absolute contraindication to choose and pick patients with a little bit higher portal hypertension. So when we say CSPH, it is clinically significant portal hypertension. It's not an absolute contraindication to liver resections. Obviously, age is also not a contraindication anymore. So how do we select these patients? Obviously, we go through the liver tests, check their Child-Pugh score, do their MEL scoring, and this tells us about the status of the underlying liver disease. Location and number of tumors is also very pertinent to the surgeons, and obviously we go through the liver volumes by the help of our radiology colleagues. So 2 types of resections are generally offered. The minor resections are when you resect 2 or less segments, and major resection when you resect 4 or more segments. So the criteria, established criteria are Child-Pugh A, bilirubin of less than 2 for minor, and absence of ascites, and a platelet count of more than 100,000. For major resections, it's more stringent. The bilirubin needs to be less than 1. There should be absolute absence of portal hypertension. And when you're contemplating a major resection, think of portal vein embolization and the FLR, which needs to be more than 40%. So what are the limitations of resection? We all know that these patients have reduced hepatic reserve, and obviously this leads to increased morbidity and mortality, and the multifocality of these tumors. So about 20 to 60% of even the small HCCs have multicentricity. And the last problem is that they have a higher recurrence rate when you resect these tumors. Okay, so these kinds of patients, we are looking at the comorbidities. Obviously, the performance status has a major role to play. We have our cardiology and pulmonology colleagues to give fitness to these patients. Each one of these patients undergo a minimum laboratory testing to let us know about the child score, the MEL score, and liver stiffness measurement is also done in some of the cases. Then as surgeons, we are interested in to know the HVPG. Endoscopy is done by our hepatology colleagues. But as surgeons, really the tumor burden, the number, size, location, and the vascular invasion is the most important area where, as a surgeon, we are constantly concentrating. Also, very important is the relationship of the tumor with the most important anatomical structures like the bile ducts, the hepatic veins, and the portal vein. So this is a general way to select a candidate. So just a small slide on evaluation of the portal hypertension. HVPG measurement is the gold standard, and a cutoff value of less than 10 millimeters has been set. Obviously, it is an invasive method. For all major resections, this needs to be done. However, for smaller resections, we have indirect non-invasive methods which translate into the information. So we have ultrasound-based elastography, fibroscans, and then we have other surrogate markers like varices, thrombocytopenia, splenomegaly, and ascites. So all of these need to be looked into. So one of the papers by Torzilli in 2013 looked at the data and found out the factors for overall survival and overall recurrence. So they found out that macrovascular invasion, tumor size more than 5 centimeters, preoperative bilirubin, varices, and obviously cirrhosis affects the overall survival. But it's the microvascular invasion, poor histological grade, and satellite nodules and multifocality of the disease, which is more pertinent for the recurrence. So both these, obviously overall survival and recurrence, both are very important. Okay, so in the last 20 years, there has been a paradigm shift. People and the surgeons especially and the interventional radiologists have become more and more aggressive. This has taken place mostly in the Chinese, in China, and mostly in the Asian countries, in Japan, Korea. I think it's because of the better surgical techniques and better anesthesia, intensive care, and all of this has happened in the setting of living donor liver transplant setups mushrooming all over Asia. And what is that paradigm shift? Okay, so this is a new sort of algorithm which the Chinese group, they've gone on and tried to improve upon the BCLC staging system. So if you just look at this slide, you will come to know how things have become more and more aggressive through the 90s and then till today. So the BCLC stage 0, where we would offer resection or ablation, the current situation is that we can offer liver transplant along with TACE and RFA. Again, as Dr. Zahid said, it's the shift from the left to the right. Again, I'm not going to go too much into the detail of the stage A and 0, but I'm going to go in stage B and C, where the things have really changed. Back in the day, the original algorithm of BCLC would recommend chemoembolization of stage B tumors and systemic therapy for stage C tumors. And now, if you look at the data, and they've come up with this algorithm where currently people are trying to do surgical resections and TACE along with in the stage B, as well as in stage C, they are looking at surgical resection and sorafenib. So it is, as Dr. Zahid said, a shift from the right, from the left to the right. So you can dwell upon this slide a lot longer, and you will find that more and more people are doing more aggressive things, and surgical resection is taking the mainstay. It's also the stage A, where they're not recommending liver resections, but rather liver transplant and TACE as a combination has proved to be better for these stage A tumors, where earlier you would do surgical resection and LT with RFA, etc. Anyway, this is again the same thing. Don't need to go into the detail. Now we're going to touch upon portal vein tumor thrombus. This is a surgical challenge, it has always been, and a lot of innovations have come into play. It's not a rare situation. About 50%, some studies say up to 40% of the HCC will have some kind of portal vein tumor thrombus. They were synonymous with extremely poor prognosis and were called advanced stage diseases. And traditionally, only sorafenib used to be offered to these patients. However, things have changed. The Japanese have come up with a classification of anatomical classification of portal vein tumor thrombus. So it's a VP1, VP2, where a subsegmental branch is involved, then a main first order branches of the portal vein. If it's involved, it's VP3, and main portal vein involvement is VP4 in this classification. So what the algorithm they've come up with is HCC with portal vein tumor thrombus. Obviously, you need to still select patients in Child-Pugh score A and B, more so in A. And up to the second order branch, your options are, this is for especially for downstaging protocols, your treatment options are hepatic resection, TACE, SPRT, TARE, and systemic hepatic artery infusion chemotherapy. So these are the the options which are now coming forward, and more patients are getting liver resections, RFAs, and liver transplant. And this is that paradigm shift, which is gradually coming into play. Okay, so this is the paper which is looking at about 455 patients. This is again coming out of Shanghai, I think. And this looked at the data of the very early deaths, which is less than 3 months, and then between 3 months and 24 months, the survivors, and the survivors of more than 2 years. If you look at this, so what they did, so they enrolled about 456 patients, and 51 patients died within 3 months, and 291 patients died between 3 months and 24 months, and at least 98 patients survived more than 2 years. So once we looked at the data, we found out from the discussion the poor prognostic features for the patients who did not survive 90 days. Most of them had large tumor, high bilirubin, high AFP, and positive radiological ascites. The patients who survived more than 3 months, less than 24 months, had higher AFP, and then clinically significant portal hypertension and increased extent of the portal vein tumor thrombus, while the tumors were poorly differentiated. So between the patients who survived between 3 and 24 months and more than 24 months, the good prognostic features were lower AFP, better liver function, smaller tumor, favorable tumor differentiation, early grade tumors. So another important topic is hepatic vein invasion by these tumors. This is less common than portal vein tumor thrombus. About 4.5% patients have hepatic vein tumor thrombus. So again, the Chinese and the Japanese have tried to classify it as peripheral main and tumor thrombus involving the inferior vena cava. These are also considered advanced, and only sorafenib used to be the treatment at one point in time, with a median survival time of 8.1 months. So if you look at these curves, they have gone through and resected about 600. The total cohort was about 1,000 patients, in which the liver resection patients fared much better, and we'll come to that slide again. Then again, in the second paragraph, there were 245 patients with inferior vena cava tumor thrombus, 446 patients with hepatic vein, not the peripheral branch, but the main hepatic vein tumor thrombus. These were matched according to the propensity scores, and you can look at the results. So if you look at the second line of this slide, so the peripheral hepatic vein tumor thrombus, there were 305 patients, and median survival time was 4.85 years, which was as good as 4.67 years in the main hepatic vein group. Once the tumor approaches the IVC, obviously the median survival time reduced to 1.37 years. But if you look at the third line, you will come to know that the recurrence-free survival was much higher in the peripheral hepatic vein tumor group than the main hepatic vein tumor group. So these were obviously statistically significant. But if you look at from the old philosophy, once tumor thrombus in the hepatic veins, the median survival is less than 6 or 8 months, is now going to 4 and 5 years time. So this is the paradigm shift we spoke about. A concomitant portal vein tumor thrombus is a bad sign. And if you have tumor thrombus both in the hepatic veins and the portal vein, then the prognosis and overall survival is decreased considerably. And I think it is less than 20 or 30% in 5 years' time if you have a hepatic vein and a portal vein tumor thrombus. So again, the multivariate analysis identified prognostic factors in which there was, as the number of tumors increased, if there was concomitant portal vein tumor thrombus, if there were varices, and if the grade of the tumor was poor, then these were the bad prognostic factors. Anyhow, so the boundaries have been pushed, and more novel techniques are coming in the modern era. Not much relevant in the case of cirrhosis, but however, hepatocellular carcinomas have been dealt by these techniques. One of the most important factors in all these novel techniques is about the portal vein embolization. We all know how it is done and what are the uses. For larger resections, you need a preoperative portal vein embolization, and it increases the FLR from, let's say, 20, 30 to 40, 45%. Also, sequential TACE can be performed to control the tumor growth between portal vein embolization and liver resection. Okay, ALPS, not commonly done for cirrhotic patients. However, it is one of the techniques in which there is liver partitioning and portal vein ligation. It's just to enhance the FLR. Some of the very novel and extreme situations in which ex situ resections have been done with auto transplantation. This is usually done for large cholangiocarcinomas and tumors which are abutting the hepatic veins. Anyway, just to tickle your fancy, these slides were added. In the nutshell, the ex situ surgery should be done by surgeons who are familiar with advanced technique in liver resection and preferably in liver transplant units. Okay, so this was a big meta-analysis, and somebody has tried to look at more than about 200 studies, and a systemic review was published in 2006. They have included all the treatments for HCC, but I'm going to limit myself to liver resections. So these are some of the recommendations. The surgical resection margins need to be 2 centimeters. The 2 centimeter surgical margin is better than 1 centimeter, and the grade of recommendation is moderate. The survival benefit, obviously, the laparoscopic surgery has a bit of a survival benefit. This is my last slide. Anatomic resection is considered better than non-anatomic resection and should be recommended. Grade of recommendation is still low. Adjunct lipoidal therapy may be considered for patients undergoing surgical resection. Grade of recommendation is low. Immunotherapy may not be considered in patients undergoing surgical resection. Again, grade of recommendation is high. And portal vein embolization may not be considered in patients undergoing surgical resection. Again, grade of recommendation is low.
Thank you very much, Dr. Haseeb, for an excellent talk. Continuing with the surgical treatments for HCC, our next speaker is Dr. Nusrat Yar Khan, who is consultant liver transplant surgeon at Shifa International Hospital. He will be updating us on traditional and expanded criteria for liver transplantation in HCC.
So today I'll be talking about traditional and extended criteria for liver transplantation in HCC. Sorry for the delay. So we start again. So we'll be talking about traditional and extended criteria for liver transplantation in patients with HCC. I have no disclosure to announce. So, I mean, everybody discussed about it, but why HCC important? It's the most prevalent primary liver tumor and 4th leading cause of cancer death. It's 80% cases are due to liver cirrhosis, and there is a 3 to 10% incidence of HCC in cirrhotics. And in Pakistan, we have high incidence of hepatitis B virus and hepatitis C virus. Only curative treatments available is either liver transplantation or liver resection. Dr. Haseeb has discussed liver resection. So liver transplantation treats HCC and the liver disease both at the same time. And about 15 to 50% transplants we do are for HCC. Why we need a criteria? So the first transplant done for HCC was about half a century ago. That was in 1967 when Shahzad at Colorado done a liver transplant on a 19-month-old girl. And she had a tumor recurrence within 3 months' time and survived for 13 months. So in early 70s and 80s, the recurrence was too high, and until late 80s, this is a paper published in Annals of Surgery, and where they transplanted 93 patients, and 50 were for HCC. And there was an early recurrence of 64.9% at 3 months, and only 3 patients survived for more than 5 years. Most probably, this was because of they do not have a good imaging techniques available to diagnose the extent of the tumors and their location. And also, it was the immunosuppression was not. They were early period, and the immunosuppression was playing a role in tumor recurrence as well. So, U.S. Department in 1989, they declared HCC as a contraindication to liver transplantation. So there was a new era that started in 1996 with a milestone study of Muzaffaro, and that was published with the name of Milan criteria, where they found out that in cases when they transplanted cases where there is a single nodule less than or equal to 5 centimeter, or there are 3 lesions less than or equal to 3 centimeters with no gross vascular invasion, no distant metastasis, no lymph node involvement, the 4-year survival was around 75%, and the recurrence rate was less than 10 to 15%. And the liver transplant outcome was not different from non-HCC cirrhotics. So this was the first criteria in which completely changed the dynamics at that time. But Milan was too restrictive, and only very small fraction of the total HCC patients will benefit from transplant. So there was a need to include more patients, and then people started looking for different criteria. Milan does not cover tumor biology or tumor markers, which are most important predictors of tumor recurrence and behavior. And there is a study, Todo et al., of 316 LDLTs for HCC from 49 centers in Japan, and only 1/3 used the Milan criteria, and others did not. So we talk about, before moving to the extended criteria, we need to discuss the importance of biological parameters, which are very important. So the most important thing is tumor biology. So degree of differentiation into well-differentiated, moderate, or poorly differentiated is very important. Microvascular invasion, again, is a very important biological feature. Microsatellite lesions is again, probably these are more important than the size and the number of the tumor. So next important thing is the biochemical markers, and the alpha-fetoprotein is a very important prognostic tool. And in Shifa, we have experience, we have published this paper where we found out that an alpha-fetoprotein more than 600 nanogram was a poor prognostic factor for patients within UCSF or outside UCSF criteria with more than 50% recurrence rate. And this was supported by another study by Hamid et al., that alpha-fetoprotein more than 1,000 nanogram is associated with increased risk of post-transplant recurrence, even with HCC fulfilling UCSF criteria. And recently, it has been recently incorporated into UNOS for listing the patients on for transplant waiting list. So the next important biological marker is DCP or PIFCA2. So pre-op DCP levels have been reported as possible indicators of microvascular invasion in HCC. correlation between high PIVKA2 level and HCC recurrence post liver transplant. And recently there is a morale score which is using square root value of alpha fetoprotein and DCP. So the 5-year recurrence-free survival and overall survival rates in patients beyond Milan with low morale score were 66.3% and 82.6% respectively. Low morale score patients showed low risk of recurrence regardless of presence of portal vein invasion. There is a role of PET scan as well, which is not as such, there's not much evidence available, but tumor size more than 10 centimeters is associated with high risk of microvascular invasion, poor differentiation, and metastasis. And there is an evidence to do PET scan and to look for metastatic deposits. In context of LDLT, tumor size cutoff 10 centimeters has been used in combination with PET scan for patient selection at National Cancer Center, Korea. And this is published in 2016. However, the sensitivity of PET scan for HCC varies with tumor grade and location of metastasis, and optimal SUV cutoffs to predict recurrence are yet to be established. So it's only used in high risk cases, mostly with tumor size more than 10 centimeter. So there are, before we discuss extended criteria in detail, just quickly to talk about bridging therapies, because we use them for downstaging or for the patients who are waiting for liver transplant. So bridging therapies depend on tumor location, size, number, and hepatic functions, and it includes liver resection, percutaneous ethanol injection, radiofrequency ablation, microwave ablation, transarterial chemoembolization, radioembolization, and stereotactic radiotherapy. And this all has been discussed in detail by my colleagues earlier. So locoregional treatment response, a good response to a locoregional therapy reflects favorable biology for HCC that helps in making a decision for transplantation. And there are few studies which supported this argument. So DeCarlis and colleagues, their study says that 5-year recurrence-free survival is significantly lower for patients experiencing radiological tumor progression after locoregional therapy. Lay and colleague, both radiological and biological progression, that is alpha fetoprotein slope more than 15 nanogram per ml per month is a risk factor for poor outcomes. Milan criteria reassessed after locoregional therapy might be more predictive than the initial Milan criteria. And then comparable post-operative, post-liver transplant outcomes for successfully downstage patients to those initially within Milan and primarily transplanted. So patients who has been downstage have good outcomes as well. So now we talk about these different criteria. So the first criteria, as we already discussed, was a Milan. And then the next criteria was from University of California, which says solitary HCC less than or equal to 6.5 centimeter, or 3 nodules with largest not more than 4.5 centimeter, and a total tumor diameter less than 8 centimeter. And then there is a modified Milan or up to 7 criteria, which means tumor number plus size of the largest tumor less than or equal to 7 centimeter. Then there is a Tokyo University criteria, which is a 5-5 rule, HCC not larger than 5 centimeter and no more than 5 nodules. Then there is an Asan Medical Center criteria, HCC not larger than 5 centimeter, 6 or fewer nodules without gross vascular invasion. So these 5 criteria, they only looked into size and number. And they all have the similar, more or less similar overall survival, which is between 75 to 85%, 5-year overall survival. So then the only criteria which actually considered biopsy is the Toronto criteria. So Toronto criteria says any tumor size or number, if pre-transplant tumor biopsy showed no poor differentiation, no major vascular invasion or extrahepatic disease. So any number, any size without poor differentiation can be transplanted. So that is Toronto. The KSU University criteria, HCC less than 5 centimeter and a serum PIFCA2 less than or equal to 300 ml international unit per ml. And it has been refined by adding neutrophil to lymphocyte ratio later. Then Hangzhou criteria, HCC more than or equal to 8 centimeter if serum alpha fetoprotein less than 400 nanogram per ml, only again in grade 1 or 2. So the Toronto criteria is very helpful, but there are risks of biopsies, the potential complications, which Dr. Atif already mentioned, the risk and seedling of cancer in the tract, which is 1 to 2%. So there is another extended Toronto criteria where they biopsy all the patient outside Milan criteria. And then there is Kyoto University criteria, less than or equal 10 tumors, not more than 10 tumors, all less than 5 centimeter, and serum levels of PIFCA2 less than or equal to 400 international unit per ml. So they used in addition to size and number, they used the biological marker. And then there is another criteria, Tosso et al., where they looked into tumor volume plus alpha fetoprotein. So total tumor volume 115 centimeter plus alpha fetoprotein less than or equal to 400. So if you look at the overall survival of all these criteria, so they're all between 70 to 85%. So it's not much difference. So what we do, what is our criteria? So since 2012, what we are practicing is no evidence of extrahepatic disease, no portal vein tumor thrombosis. If a patient is within UCSF criteria, we offer upfront liver transplantation. Outside UCSF criteria, largest tumor size up to 10 centimeter, any tumor number and alpha fetoprotein less than 1000 nanogram per ml were also considered for liver transplantation without downstaging. Patient with alpha fetoprotein more than 1000 nanogram per ml and outside UCSF criteria were considered for downstaging. And for downstaging, they can have TACE or all possible locoregional therapies, as it depends on the size, number, and location of the tumor, and plus chemotherapy. Most of them had sorafenib. If a patient has an anticipated delay of more than 3 months in liver transplantations, a locoregional therapy used as a bridging therapy as part of our protocol. A drop in alpha fetoprotein to less than 1000 nanogram per ml and a radiological response at 6 to 8 weeks was used to determine effectiveness of locoregional therapy and candidacy for liver transplantation. So since April 2012 till December 2019, total 898 living donor liver transplants were done in our center. Out of these, 242, which is 26.94%, were HCC on explant histopathology. We looked into the preoperative factors associated with less than or equal to 50% recurrence-free survival at 4 years. On multivariate analysis, the independent predictors are alpha-fetoprotein more than 600 nanogram per ml and microvascular invasion. When alpha-fetoprotein was more than 600 nanogram, around 90% of the tumors were poor grade on explant histopathology, and 75% of the tumors outside UCSF criteria have more than 600 nanogram of alpha-fetoprotein. So estimated 4-year recurrence-free survival was 78% for the entire cohort. When alpha-fetoprotein was less than 600 nanogram, 4-year recurrence-free survival for well to moderate was 88%, and for poor grade, it was 73% when alpha-fetoprotein is less than 600. When alpha-fetoprotein was more than 600 nanogram, recurrence-free survival was 53% for well to moderate and poor grade, and 0% for poor grade tumor respectively. So we concluded that alpha-fetoprotein less than 600 nanogram have acceptable outcomes, whereas alpha-fetoprotein more than 600 nanogram per ml, a preoperative biopsy to rule out poor differentiation. So it's very important. So rather than doing a biopsy on all tumors or beyond Milan criteria, which Toronto believes, if you just do biopsy on patients who have alpha-fetoprotein more than 600 to look for poor differentiation, that will help. So this is the survival curve where if you look alpha-fetoprotein less than 600 in UCSF patients. So patients within UCSF criteria with alpha-fetoprotein less than 600, their recurrence-free survival is 89%. And then the next group is alpha-fetoprotein less than 600 outside UCSF. They still have a recurrence-free survival of 64%. Whereas in the other two groups, where whether they are within UCSF or outside UCSF with the alpha-fetoprotein more than 600, their recurrence-free survival is 26% and 33%. So alpha-fetoprotein more than 600 has a very important statistically. This is another survival graph which shows association of alpha-fetoprotein with grade of the tumor. So if alpha-fetoprotein is less than 600 and grade is well to moderate, then recurrence-free survival is 88%. And if alpha-fetoprotein is less than 600 and the grade is poor, still the recurrence-free survival is 73%. And then the other two, where alpha-fetoprotein is more than 600, well to moderately differentiated tumors still have a recurrence-free survival 53%, and patients with poor grade has a 0 recurrence-free survival. So the important message is that patient with alpha-fetoprotein more than 600, but with well to moderate histopathological differentiation, they still have a 53% recurrence-free survival. So a biopsy can help to differentiate two groups. So when we talk about extending the criteria, so what we conclude, liver transplant remains the best treatment option for HCC patients, selected HCC patients. Milan criteria remains the benchmark, but it's too restrictive. Tumor marker and biological features are more important than tumor size and number. In fact, tumor size and number is an indirect reflection of the biological features. But if we can directly look into the biological feature, histopathological features or the tumor markers, they are better predictor of tumor behavior. In high-risk patients, tumor biopsy and PET scan can be very helpful. Downstaging can help a few patients to become transplantable. We're still gathering this data in our department. Patient with tumor thrombus in segmental and lobar portal vein can be considered for LDLT after downstaging. Dr. Abu Bakr will be discussing this in detail later. An extensive research into predictors of recurrence, such as microvascular invasion, could make refinement of selection criteria possible. I'm sure in coming days, we have a biological marker, which will tell us about microvascular invasion and differentiation to such an extent that will help in selecting the patient for transplantation. Thank you.
Thank you, Dr. Nusrat. This was such an elaborate talk. Last but not least, I'm going to invite Dr. Abu Bakr Hafiz Bhatti, who is consultant liver transplant surgeon at Shifa International Hospital, for the final session of the seminar. He will be telling us about the role of liver transplantation in HCC with macrovascular invasions.
Okay, good afternoon, everybody. I would like to thank the Pakistan Society of Hepatology, Shifa International Hospital, and our expert panelists for this opportunity. So today I'm going to be talking about the role of liver transplantation for HCC in patients with macrovascular invasion. So we've had some excellent talks before, and I think I'm just going to take it a little further. I have no disclosures. So I'll be talking about the standard treatment for macrovascular invasion. What is the rationale for liver transplantation in patients with macrovascular invasion? How do we diagnose and grade macrovascular invasion? And what are the prognostic factors in patients with macrovascular invasion? So this is the standard management protocol. We all know that BCLC is the most widely practiced protocol in the world for HCC management. And if you look at the advanced stage, which is stage C, that is where you have the portal vein invasion patients. So it is actually grouped alongside patients with nodal metastases and extrahepatic disease. Generally, the recommended treatment is sorafenib, and the overall survival is in between 6 to 14 months. So the question is then, why bother and why consider liver transplant for these patients who have such poor prognosis? So basically, macrovascular invasion is found in 10 to 40% of patients with HCC, and it has a median survival of 2 to 6 months. But disappearance of tumor thrombus with TACE, TARE, SPRT, and sorafenib has been documented in up to 1/3 of the patients. So basically, there is a chance that somebody who has HCC with macrovascular invasion, he might have good biology. Moreover, macrovascular invasion may represent contiguous spread and remain localized for a reasonable time before distant spread occurs. So there's a potential for therapeutic window where we can kind of give them some treatment and make a difference. Moreover, we already have some evidence which suggests that long-term survivors with resection and liver transplant do exist. So there is a treatment effect as well. So if we combine all of these things together, and if we can remove the tumor at the right time before metastasis develop, we have a probability of long-term survival as well. But before we actually discuss the management of these patients, I think we need to know how to diagnose these patients, because that is also a dilemma. And a lot of times we see patients who have been incorrectly diagnosed to have malignant portal vein thrombosis when actually it is bland portal vein thrombosis. Generally speaking, you can use, we use dynamic CT scan of the liver, but you can use an MR as well. And a tumor thrombus would behave much like HCC. So there would be arterial enhancement with venous washout, and the sensitivity would be anywhere between 80 to 100% in these patients. But there has been a recent development, and a VENA criteria was proposed by the UCSF group, and actually they looked at patients who were listed for transplantation between 2004 and 2011. So out of 467 patients, there were 59 patients who had a portal vein thrombus. Expert radiologists reviewed these patients, and they were actually blinded to the primary diagnosis. So they labeled 12 patients to have tumor portal vein thrombosis. These radiologists also identified certain risk factors which were associated with the presence of portal vein tumor thrombosis. And these were kind of called the VENA criteria. So it is arterial enhancement with venous expansion, new vascularization around the tumor thrombus, presence of the tumor thrombus adjacent to the hepatocellular carcinoma, and presence of an alpha-fetoprotein level of more than 1,000. And the authors noted that if 3 or more factors were present, the sensitivity of this criteria to predict portal vein tumor thrombosis was 100%. The authors actually went on to see the outcomes in these patients, and you can clearly see here that patients who were categorized as bland portal vein thrombosis or no portal vein thrombosis patients, they had 10-year survival, which was kind of in excess of 50%. But those patients who were labeled to have portal vein tumor thrombosis, they did not even reach 3 years, and all of them were actually dead by that time. So this goes on to show that if we use all these factors when we're trying to diagnose portal vein tumor thrombosis, we can probably accurately diagnose these patients. Another important factor is the extent of portal vein tumor thrombosis, because it has prognostic and treatment implications. I think Dr. Haseeb has probably mentioned this before. So the most widely used one is the Japanese classification for portal vein tumor thrombosis, and they have again categorized portal vein tumor thrombus into 5 different types, where VP0 is when there is no thrombus in the portal vein, VP1 is when you have segmental portal vein tumor thrombus, VP2 is when you have sectoral portal vein tumor thrombus, and VP3 is when you have the right or the left portal vein involved. And when the tumor thrombus extends into the main portal vein, then it is called main BP4. The other most commonly used classification is the Cheng's classification. And actually, it is not much different from the Japanese classification, other than the fact they have included SMV tumor thrombus in their classification. To me, actually, it's an overkill because it doesn't really matter. Once you have the tumor in the main portal vein, I don't think you're going to change the prognosis much. So, but anyway, it is used frequently. So what are the prognostic factors for liver transplantation in patients with macrovascular invasion? This is a busy table, but I am going to kind of focus on the important things here. So if you look at the numbers, you notice that we don't have a very big numbers when it comes to liver transplantation for patients with macrovascular invasion. The largest study was by Soin and colleagues from India, which included 45 patients. The second largest was by Chowi and colleagues from Korea, which included 34 patients. And the third one is actually from Shifa International Hospital, which included 27 patients. If you look at the downstaging protocols, you would see that not all the studies have used a downstaging protocol, but from 2017 onwards, there has been a trend to use downstaging before liver transplantation, and a variety of downstaging protocols have been used in these studies. When you look at the survival, and in particular the overall survival, if you consider that as the endpoint, so you can see at the top, the 2-year survival can be as bad as 23.6%, but as good as 100% as well. So this difference actually represents the difference in patient selection, the downstaging protocols, the treatment duration that has been given to these patients, and this results in kind of this variable outcome. But encouraging results have been seen, and there are a lot of studies now that are reporting a 5-year survival in excess of 50% for these patients. I would also like to specifically point out here that almost all these studies have been done in the living donor liver transplant setting. And there's only one study that is highlighted in blue, that is by Asalino, which is not a living donor liver transplant study, and it was predominantly a Western experience, and they included patients from Europe and North America. Actually, 12 centers contributed 30 patients in a period of 14 years. And they also showed a 5-year survival of 60%. But the most important aspect of this table, I guess, is the identification of risk factors. What are the risk factors which preclude liver transplantation in these patients? And again, a number of risk factors have been identified, but if I have to summarize, I would say that there are three more important risk factors. So one is presence of main portal vein tumor thrombosis. The other is alpha-fetoprotein level at the time of transplantation. And the third is response to downstaging. So you have to consider these things when you are considering liver transplant for these patients. And I'm going to touch on them a little bit in detail in my presentation. This is a list of studies that were discussed in the table. So Chowei and colleagues from Korea. So they looked at the impact of extent of portal vein invasion on outcomes after liver transplantation, and both the disease-free survival and overall survival. You can clearly see that the 5-year survival in patients with segmental portal vein tumor thrombosis was in excess of 50%. But when the tumor thrombus extended into the right or the left portal veins, the outcome was really bad, and it was around 14 to 15%. They also showed that patients who have segmental portal vein tumor thrombosis, their outcomes are comparable to those patients who have HCC with microvascular invasion. And just to clarify, microvascular invasion is not something that you predict preoperatively. It is something that you diagnose on explant histopathology. So essentially, patients with segmental portal vein tumor thrombosis have comparable outcomes, and they can undergo upfront liver transplantation. Another factor that they looked at was the alpha-fetoprotein level. And those patients who had an alpha-fetoprotein less than 100 at the time of transplantation, they had excellent outcomes, like 90% and 71.3%. But when the alpha-fetoprotein level was more than 100, again, the outcomes were not that great. Now, these results were actually confirmed in the study by Soin and colleagues from India, where they reported that alpha-fetoprotein, when it was more than 100, it was a poor predictor of recurrence-free survival and overall survival. They also showed that whether patients received downstaging or not, the outcomes were comparable. But actually, these groups were different because patients who had upfront liver transplantation had limited portal vein involvement, while those patients who had transplant after downstaging, they generally had extended involvement into the right or the left portal vein as well. So we also published our results, and I just told you that we had a total of 27 patients who underwent liver transplantation for macrovascular invasion. We just recently published this in May 2021. And I would just discuss the most important findings of our study. So there were 27 patients, and we grouped them based on whether they had downstaging or not. So there were 15 patients who had downstaging, and there were 12 patients who did not have downstaging. So out of those patients who had downstaging, those patients who had good response and an alpha-fetoprotein less than 100 at the time of liver transplantation, they had very good outcomes. But patients who had either a poor response or an alpha-fetoprotein more than 100 at the time of transplantation, they had extremely poor outcomes. In the other group that underwent upfront liver transplantation, you can see the patients, if they had segmental portal vein involvement or if their alpha-fetoprotein was less than 100, they were all alive at the last follow-up. But patients with more extensive portal vein involvement or a higher alpha-fetoprotein, they had extremely poor outcomes, and only 1 out of 9 patients was alive at the time of last follow-up. So I would briefly summarize, and I guess this is very important. When you are able to downstage patients with macrovascular invasion, it does not matter what is the degree of macrovascular invasion. As long as you have treatment response, you have good response to downstaging, and your alpha-fetoprotein comes down below 100, you are good to go. But if you are not able to downstage patients because they have severe liver failure or something else, then the degree of macrovascular invasion becomes important. And you cannot transplant those patients who have a right or a left portal vein involvement. So basically, these two good groups that we had, we combined them to make a low risk group of microvascular invasion. And here you can see that at 4 years, the recurrence-free, actually overall survival. This was overall survival. So at 4 years, the overall survival was 85% in these low-risk patients. But the other high-risk patients, actually all of them almost were dead by the time we collected this data. So again, it goes to highlight that the 3 most important factors are downstaging, alpha-fetoprotein level, and degree of macrovascular invasion at the time of transplantation. So here I would like to share a success story, and actually it's all about teamwork. You know, these are complicated patients. They have some degree of liver failure, large tumors, and you need dedicated transplant surgeons, hepatologists, and interventional radiologists to kind of come together and manage these patients. Otherwise, these type of outcomes are not possible. So this patient, probably we saw him more than 6 years ago. And here you can see in the figure A that he had a right lobe HCC, which was involving the right portal vein. There was arterial enhancement. There was new vascularization as well. And in figure B, you can see that there was venous washout with venous expansion. So it pretty much fulfilled all the criteria that are mentioned in the Avena criteria. So this patient had 4 sessions of TACE, and over a period of 12 months. After that, in figure C and D, you can see his imaging after 4 sessions of TACE. So there was very good response in the primary tumor. There was reduction in the arterial thrombus. There was reduction in neovascularization as well. And on the venous phase, in the green arrow, you can see that there was actually a recanalization of the portal vein. So we kind of thought that this was excellent response, and plus a patient who did not develop metastases over a period of 12 months. We offered him liver transplant, and I think he has crossed more than 5 years now, and he's doing well. So it is about teamwork, and if you have dedicated individuals, you can kind of achieve these outcomes. So I'll just, in the interest of time, I'd like to finish here by concluding that all HCC patients with macrovascular invasion, if they do not have metastasis, should be considered for downstaging when feasible. Now, good radiological response, alpha-fetoprotein response, and metastatic workup improves patient selection for living donor liver transplantation. Patients with segmental portal vein tumor thrombosis and low alpha-fetoprotein can be considered for upfront living donor liver transplantation. An ideal alpha-fetoprotein cutoff before liver transplantation in this patient group is not yet defined, but alpha-fetoprotein less than 100 appears to be safe. Inclusion of PET scan, PIVCA2, and FPL3 in the future might improve patient selection in the future. Thank you.
As we know, we have been struggling how to treat HCC. This has been such a devastating illness. It's like with the new emerging therapies coming in, especially the immunotherapy coming in, we still have hopes. I just have one comment and a question to all the panelists. So far, the experience we have with Viv-Atezo, which is like IMBRAVE 150 trial, is currently not recommended in a post-transplant recurrence because the risk that the graft will get rejected. So any comments about that? Because this is a double-edged sword, if we intensify the immunosuppression, the effect will not be that great. So what's your view about that? Can we expand this indication or not? Because this is the best available therapy we have got so far, and we cannot offer it to the people who have post-transplant recurrence, which we do see.
Can we have Dr. Shahzad Riyaz's opinion on this, please? Dr. Shahzad, is he here? Currently, it is not recommended to be used in liver transplant and organ transplant patients in general because, as you understand, the mode of action is based on immune modulation. And in such patients, we are using immunosuppressive therapy to prevent rejection, which is, not the right setting to assume that this treatment will work. But certainly, there is no data on this subject. It has not been tried. And this is an assumption which theoretically holds true, not only for liver transplant, but for organ transplant patients in general, and also for those on heavy immunosuppressive therapy. So certainly not recommended today. We don't know if we collect data and we can prove this point that it does not make much practical difference. We may start using it in future. So the current recommendations do not recommend it in people who are on immunosuppressive therapy. So Atezo and Bev works very well, we know, but not in this class of patients. Thank you.
Thank you so much. It was really a comprehensive talk by all of my colleagues covering this vast topic and covering every aspect of the management. As a radiation oncologist, I just want to add few words about SBRT. A lot of data has been coming on SBRT, stereotactic body radiation, not only in the unresectable HCC, but also as a bridge therapy before transplant. And it has shown about 20 to 27% complete response in post-transplant settings, and about 30% more than PR, partial response. So overall response rate is about 40%, especially if it has been done before the transplant. Thank you so much.
Bismillah Rahman Rahim. I am Dr. Kashif. I have
Thank you so
few
much, sir.
comments to say. Yes, sir. It was a very, very nice and well done program by your group. I must congratulate Dr. Shahzad and all the team for the excellent presentations and time management. That is the most important thing. The time management was excellent. We have seen this in the too many these kind of seminars that people they do not follow the timeline, but it was very excellent presentation. I have a question regarding the screening and diagnosis of HCC. Dr. Saleh did not mention PIVKA2, while Dr. Abu Bakr in the last slide, he mentioned for PIVKA2. So my question is from Dr. Saleh, if he's around, how frequently should we go for the PIVKA2 test while diagnosing hepatocellular carcinoma? Dr. Saleh, if he's around.
Assalamu alaikum, sir.
Wa alaikum salam.
Sir, there are so many markers, including the L3 portion, the glypican 3, the miRNA, and PIVKA2, and all these are there. I just stuck to the one which are mentioned in the guidelines. And even the European would not support these because they say that they only help in 7 to 10% of the times. However, having said that, we routinely at our center screen them with alpha-fetoprotein as well as with PIVKA, and it helps in identifying patients specifically. Sometimes, even yesterday I saw a patient where the alpha-fetoprotein level was around 3.7, was the PIVKA is more than 1400, and then you would ask that it's better to go for a screening with something else rather than ultrasound alone. So I do agree with you. Till that time, we had robust data to say and recommend it at the recommendation level. All these things
actually
are not.
The problem is, Dr. Saleh, the problem is now that this test is available and people are doing this test without realizing, because the cost effectiveness is there. So we have some guidelines for this, that one has to basically go with this when we have to do this test, because our colleagues sitting in the periphery and they just follow our prescriptions and they are doing it. So there must be some guidelines for this, within whom we should do this, or when there is clear-cut diagnosis. It should not be done, because then it will not be cost effective. And my second question is regarding immunotherapy. Who should start the immunotherapy, either the oncologist or the hepatologist? Because with sorafenib, I'm sorry to say, we have a very bad experience when the oncologists have started these therapies at their own. And we have seen the patient coming to us with complication. Even the indication was not there, and they have just started the sorafenib to these patients. So what will happen to the immunotherapy? Because I'm not interested to start the immunotherapy if the oncologist is on the board. So I would like to ask the other panelists, my senior colleagues, Dr. Farooqi and Dr. Altaf Alam, should we give this to the oncologist, or should we ourselves should start this immunotherapy in these patients?
Farooqi sir, you want to?
Yeah, thank you very much. First of all, a very great session and a very good selection of topics and time management. I think at all levels, the management of the HCC is the MDT activity, whether the whole MDT or at least the main people. Yes, we have seen that with this sorafenib, the starting without indication and the dosage issues and the monitoring issues. So I think at least this remains our responsibility that for this sorafenib, we should be having a very clear, protocols, and we should publicize it everywhere, because this is the drug which is now very cheaply available, the one which has been, from the neighbor country. And most of the people I have seen that they are, yes, I totally agree with you, that they do start it, and most of the times it is not either indicated or it's just, waste of money. So I totally agree with Kashif that we should come up with some solutions from the society that when to start. Yes, if it's a very experienced hepatologist dealing in these cases, he can start it, I mean, by its own. But I think for every GP or every medical specialist, I think it needs to be at least some team decision rather than individual decision. This is my say on it.
Thank you, Farooqi Saab. Agreed. Yeah, if you have a member, if you have an oncologist on board on your MDT, the problem will be solved. If you don't have one, if you don't have an MDT, then there will always be a problem. So I would say this is high time that we manage HCC with a properly constituted MDT. Over to Dr. Hajra for any other proceedings that she wants to.
I just have one comment. As we know, the immunotherapy has been declared the miracle of the current decade, and Bevatizo, I am brave 150, great words and great concept, but there is a scary side to it. Immunotherapy, as we know, can cause life-threatening complications, myocarditis, panhypopituitarism, colitis. Some of them can be absolutely life-threatening. So I would request, it's not just about who prescribes this, is an oncologist or a pathologist, should have sufficient experience, backup, involvement of internal medicine, and should be very, very well versed with all the possible life-threatening side effects. And the patient should receive the counseling in a written format, which all of us have. Thank you.
Excellent. Very well, valid point. I have, about 10 plus patients of mine have received immuno and VEGF therapy combined. I have not done it on any patient because I think the oncologist who is treating my patients has more experience in administering and following up these patients, because immunotherapy has been in vogue for many, many tumors and for many years. And oncologists are well versed with not only the immune mediated side effects, but also on the management of these side effects. So well said and totally agree. But I would again emphasize that you need to have the same oncologist on board on your MDT so that rational decisions can be made then and there. For example, before starting bevacizumab, all cirrhotic patients should undergo an endoscopy, and this should be decided in the MDT, not by the oncologist or not by a particular member of the team. So it is the MDT which really, in my opinion, properly constituted MDT helps in the management of difficult cases of HCC and their treatment. Thank you.
Thank you, sir. I'll request you again, Sir Honorable Professor Dr. Altaf Alam, to conclude this session.
Thank you very much. It was really a pleasure attending it. And, I'm glad that Shifa International organized it. Thanks to Dr. Shahzad Riyaz. Thanks to Shifa International, because they are the pioneers in not only in liver transplant, but in the management of liver-related problems in general. And somebody rightly said many years ago that if you have a well-established hepatology and GI service, you need to develop a liver transplant program, because it takes you many steps ahead in the management of liver diseases. It improves your radiology services, it improves your lab services, and whatnot. So, we look up to Shifa International for not only for transplant, but the provision of all the services related to liver diseases. It was a pleasure seeing Dr. Saleh, Atif Rana, Zahid, Shahzad Riyaz, Haseeb, Nusrat, and Abu Bakr Bhatti Saab presenting very, very important topics, and which helped us in understanding the management of HCC better. So I have thoroughly enjoyed it. I have learned a lot, and I'm sure everyone did. So on behalf of Pakistan Society of Hepatology, Dr. Javed Farooqi, the past president, and Dr. Kashif Malik, the current president of PSH. I congratulate Shifa International for collaborating with us to conduct this seminar, which was very informative and very well managed. Thank you very much.
Thank you so much, sir, for your wonderful words. At the end, I'm going to thank all the speakers, panelists, participants for joining us. And I'm also thankful for Pakistan Society of Hepatology and Shifa International Hospital for arranging such a wonderful academic session, hoping that we continue having such academic activities in the future. Also, at the end, I'm going to thank Roche for sponsoring the event. Thank you.